The focus is on aged care, and we have two excellent presentations. It will be recorded and made available on the NCAS website after the session. If you have any questions, please use the Q&A option. I think that's the best because we've got a lot of people online today. So the Q&A option. There will be time for questions after both presentations have been completed. So with that, Gabby's first. So if I can just introduce Gabby. Gabby is a PhD student researching the design, development and piloting of a digital intervention to support antimicrobial stewardship in residential aged care using a human-centred design approach. She began her career as a podiatrist before moving into health system project work in the UK, including equity-focused initiatives within the NHS. Gabby currently works in the digital health team at the Australian Commission on Safety and Quality in Healthcare. Thanks, Gabby.
Good morning, everyone. I'll just share my slides. Give me 1 sec. There we go.
That's great, Gabby. They're on.
Perfect. Okay. Well, good morning, everyone. My name is Gabby, and I'm here to talk about my PhD titled Human-Centered Design of an Intervention to Support Antimicrobial Stewardship in Residential Aged Care Homes. I'd like to thank my supervisors, Mel, Anne, Noleen, and Lisa, for their knowledge and wisdom they have shared with me so far. Before I begin today, I wanted to acknowledge the traditional custodians on which I present today, the Gadigal people of the Eora Nation. I pay my respects to those who have cared and continue to care for country. This always was and always will be Aboriginal land. Noleen, you did a fantastic introduction, so I'm just going to skip past this slide. But yeah, that's me as a podiatrist. It's not the most photogenic profession. So this is the only photo that I think I have of me being a podiatrist. But yeah, I mainly travelled across regional New South Wales and Queensland working in residential aged care homes, which gave me a deep appreciation for the sector and the people who work in it. So this PhD really brings together my work experience and my interest in improving patient outcomes in aged care settings. My PhD sits within the National Centre for Antimicrobial Stewardship as a part of the larger program called Radar 1H, which focuses on redesigning antimicrobial stewardship programs in the digital era. My PhD aims to design, develop, and pilot a digital intervention to support antimicrobial stewardship in residential aged care homes using human-centered design. If you're not familiar with the term human-centered design, that's fair enough. It's not a term that comes up much outside design and engineering circles, but it's a very important part of my PhD. So before I go any further, I want to take a moment or two to explain what it means. Human-centered design is an approach to problem solving that keeps the end user, the person who will use an intervention, at the core of every decision. Instead of designing something and then asking if people like it, human-centered design involves the people you're designing for throughout the entire process. This process follows 4 key stages. The process begins by exploring the real-world setting and what already exists out there. Identify needs is the second part. So from there, we focus on listening closely to uncover the real challenges end users experience in their day-to-day roles. These insights are then used to work alongside end users to develop practical ideas and solutions. And then those solutions are then tested with real users in real settings. Their feedback is used to keep refining and improving them. By keeping end users involved at every stage, this approach helps ensure that the final result is practical, easy to use, and makes a real difference in practice. So why is a human-centered design intervention needed to support antimicrobial stewardship in aged care? Well, according to data from the National Antimicrobial Prescribing Survey in 2023, On a single survey day, roughly 1 in 8 residents were prescribed at least one antimicrobial, and over a third of those prescriptions had been ongoing for more than 6 months. These figures highlight that antimicrobial use in residential aged care homes is both prevalent and complex, and there is a clear need for continued improvement in antimicrobial stewardship support. Digital antimicrobial stewardship interventions is a well-established area in hospital settings. There's a large body of research on tools such as electronic prescribing systems, alerts, and audit and feedback. And these digital interventions are associated with improved appropriate antibiotic use. But when we turn to aged care, the picture looks very different compared to hospitals. Aged care has a unique resident population, different prescribing patterns, and often far more limited access to on-site clinical expertise. And when it comes to digital interventions, what exists, whether it works, and whether it's even fit for purpose, well, this links to the first stage of the human-centered design, understanding the context, and that's exactly what our scoping review set out to do. To understand what's already out there, we conducted a scoping review. This method is used to map existing evidence, helping us understand what's been studied and where the gaps are. It gives a broad overview of the current landscape of digital antimicrobial stewardship in aged care. So this made it an ideal method for exploring the current landscape of digital AMS interventions in residential aged care homes. The aim of the scoping review was to identify studies that answered the questions: what digital interventions support antimicrobial medication management in residential aged care homes? Are they effective? And why or why not? Before we could review any study, we set out clear rules, which you can see us working out on the whiteboard. That's actually a picture of us working this section out. Every study had to tick 3 boxes, otherwise it was excluded. So for a study to be included in our review, the studies had to describe the use, implementation, and/or evaluation of digital interventions. These digital interventions had to support antimicrobial medication management, and the study had to take place in residential aged care homes. So now we had defined our eligibility criteria, we could apply them to the studies. We started with 357 studies. After screening and removing those that didn't meet our criteria, only 11 were included. This highlights how limited the evidence base still is in this area. The 11 studies came from multiple countries and settings, with a wide range of participants and facility types. This reflects a diverse but quite variable evidence base. There is a reference list at the end of these slides. I just wanted to share the diversity of slides so I don't get overwhelmed by the amount of writing. It's just, there's a lot of diversity in the studies that we've found. So with the 11 studies in hand, we could address the first question of my scoping review. What types of digital tools are being used to support antimicrobial medication management in residential aged care homes? So across the studies, 7 of them reported a range of digital interventions, including electronic health records, clinical decision support tools, electronic medication management systems, audit and feedback tools, web-based surveillance platforms, and a virtual antibiotic team. But rather than focusing on each in detail, the key point is what they support in practice. These tools mainly focused on 2 stages: the decision to start antibiotics and the review of ongoing treatment. This indicates that digital tools are primarily being used to guide whether to start antibiotics or to reassess their ongoing use. Across the studies that described the use of digital interventions, the key message that we took from it is that the technology is largely in place, but it's not being fully used for stewardship purposes. For example, one study found that almost all facilities had electronic health record systems. But when it comes to using those systems for more advanced antimicrobial stewardship use, much fewer are doing so. Only about a third of them were using them to track antibiotic use. Another important finding that we found was that prescriber access to digital interventions. One study found that nearly 60% of external prescribers, such as GPs based off-site, or those not employed by the facility, either had no access or view-only access to electronic clinical documentation and medication management systems. In other words, the people making prescribing decisions are often working without full visibility of the patient's clinical information. So when we looked at are they effective, when we looked at whether these tools were effective in improving antibiotic prescribing, that's how we answered the question, are they effective? So across the 4 studies that assessed outcomes, antibiotic-related outcomes, the results were mixed. 2 studies showed improvements in inappropriate prescribing, and I'll walk through these examples in more detail shortly. So the first study used clinical decision support tools, where the key finding was an increase in early antibiotic discontinuation, meaning antibiotics were stopped sooner when they were no longer needed. And the second study was on a virtual antibiotic team, which showed quite substantial improvements in appropriate prescribing overall. However, not all interventions were effective. Some showed no change, and one even found less appropriate prescribing. This suggests that these tools can improve antibiotic prescribing, but their impact really depends on how they're implemented and used. To understand why some of these tools worked and why others didn't, we looked at implementation findings. Across the 4 studies, a clear pattern emerged that there were more barriers than enablers. What studies reported was that systems often didn't talk to each other, and that staff had limited access to real-time information they needed. And on top of that, some interventions added to workload rather than reducing it, feeling duplicative or sitting outside of normal routines rather than supporting them. Where the tools did well, it was usually because they were easy to use, they fitted naturally into how staff already worked, and were backed with appropriate training and support. This exemplar case was a clinical decision support tool study by Bayer 2022. And this study implemented 3 clinical decision support tools. So the first tool, the change in condition tool, supported nurses in structuring how they communicated changes in a resident's condition to prescribers. The second prompted a review of antibiotic use after initiation, helping identify when the treatment may no longer be needed. And this is a screenshot of the third one because you can actually access this in infection tracking log. So the third replaced paper-based systems with a central tracking tool, improving visibility of infections and antibiotic use. But what's important is why this worked. The tools were co-designed with nurses and refined over time, with ongoing support to help integrate them into practice. So this meant that they fit into existing workflows and they improved communication with off-site prescribers. Overall, this highlights how designing tools around real-world practice can improve usability and lead to better antibiotic decision-making. And the other exemplar case was a virtual antibiotic team by Van Uyck 2022. And what's interesting is why this worked as well, is because this intervention brought together an on-site clinician with an off-site microbiologist and pharmacist who met virtually to review cases and to provide tailored feedback and advice. This meant that specialist expertise, which is often limited in aged care, was embedded into routine care. Overall, this shows that integrating specialist support into decision-making can lead to meaningful improvements in antibiotic use as well. So in summary, Digital tools are already being used in residential aged care homes, but they're not always used to their full potential. At the same time, these interventions have potential to address key gaps specific to the residential aged care homes context. We saw that with the virtual antibiotic team. And finally, an important takeaway is that how these tools are designed really matters. When they are developed with end users in mind, they're much more likely to be used and improve antibiotic prescribing in practice, which is human-centered design. It was a great finding. So what's next? Following the scoping review, the next step is to move into the real-world context, boots on the ground. This involves going directly into aged care homes to conduct observations and interviews with staff. The focus here is on listening to staff to understand their day-to-day experiences, including what's working, what's challenging, and where gaps exist. This helps build a clear picture of how antimicrobial stewardship plays out in practice and which interventions are currently used and not used. And if you'd like to keep informed and possibly involved in the next phase, you can contact me on this email address. But if you scan the QR code, it should come up with you couldn't send an it'll come up with my email address. Hopefully someone can tell me if that doesn't work, but I gave it a go and I have tested it. So, and then my references.
Thank you, Gabby. Well done. I have to say, scoping review really has given an excellent starting point for your PhD. I think you're going to be busy.
Very busy.
I'd love to ask my questions now, but we're saving them all for the end. So with that, Jo, if you could share your presentation, please. Everyone, don't forget questions in the Q&A. We're definitely going to come back to them and allow you to ask all your questions. So, Jo, while you're getting your presentation up, I'll just introduce you. So Dr. Joanne Tropea is a researcher at the Department of Aged Care, Royal Melbourne Hospital. Her research interests centre on delivering evidence-based care for older people with a vision to transform the quality of care for older people in hospital, residential aged care, and for those living with dementia. She will present on the work undertaken so far for the Immerse 2, so that's implementing effective infection prevention and control in residential aged care communities of practices for IPC leads. Thanks, Jo.
Thanks very much. Are you seeing the right screen?
We are. Yep.
Good.
Not
with all my notes. Yeah, excellent. Thanks, everyone, and thanks, Noleen. Good morning, everyone. I'd like to also acknowledge presenting on the lands of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present and emerging. I'd also like to make a mention that this project is being funded by the NHMRC. Yeah, so as Noleen mentioned, I'll be talking about the work that we've done to date on the Immerse 2 project. Okay, so Immerse 2, as the name sort of implies, it builds on what was Immerse or Immerse 1. And part of that work, we put together a 6-month pilot of a community of practice for infection prevention and control, or IPC lead nurses in residential aged care. It was a Victorian 6-month pilot, which I'll talk a bit more about in a minute. So Immerse 2, we're going national, setting up multiple communities of practice across Australia. And really there's kind of 2 key research activities involved in Immerse 2. We're co-designing the communities of practice with IPC leads and other stakeholders from around Australia, seeing if the idea is appealing, how we can get as many people as possible to attend and participate. And also the evaluation is, I guess, more comprehensive than what we did in the pilot. We're running it over 12 months and the evaluation is more comprehensive, and I'll talk about that a bit more, but it's really about assessing the experience of the community of practice. We want to know if people took what they learned from the community of practice back to their workplace, so the impact of the community of practice as well. And ultimately, the community of practice will provide a platform for IPC leads to share experiences. So these are IPC leads in residential aged care, to discuss challenges, problem solve, and develop skills together. By empowering IPC leads and fostering improvements in infection prevention and control in resi care, we hope to improve health and wellbeing of residents, which is something we all want. So I'll just talk about how we described community of practice. So we've used the approach that's been described by Wenger Trainer, who've done a lot of work around community of practice, and I think Wenger was the first person to coin the term, or maybe document it, I should say. But the idea is that there's a community, so the group of people, the domain, what they identify with, and the practice, what they do together to make a difference. So communities of practice are groups of people, in this case IPC leads, who share a concern or a passion for something. So it's IPC and trying to improve it in resi care. Something they do and learn how to do it better as they interact regularly. So the idea is that they learn together with and from one another, share ideas, problem solve together, and take what they've learnt back to the workplace. So that's what we really want, putting it into practice. So I mentioned the Victorian pilot. So it was a 6-month pilot. It involved about 20 IPC leads who participated in the community of practice, they attended monthly sessions together on Teams for about an hour every month. The research team, we provided the admin support to set it up, run the community of practice, set up the Teams meetings, those sorts of things. We're very fortunate that we had members from within the group, the IPC leads volunteer. We had 2 volunteer to be group facilitators, and we thought that was really important. In fact, that's what the literature says works well also. To have a peer rather than, an expert or someone external facilitating the session. And what the facilitators would do is act as a moderator, encourage knowledge sharing and interactions. And by using a peer, we thought it would others would feel more comfortable sharing information, asking questions, and really the facilitator, they just made sure that topics were kept on track, that everybody had an opportunity to speak and share, acting as a peer rather than an expert, as I mentioned. So after the 6-month pilot, we we wanted to know about the participants' experience, what they thought about the community of practice, the interactions, and also whether they did learn, take anything back to the workplace from the community of practice. And it was largely positive feedback. So we got this information from surveys, but also we interviewed most, if not all, I'm trying to remember if it was all, I think there were a couple that we couldn't get in touch with, IPC leads who participated in the community of practice, and really a lot of positive feedback was received. So people told us provided an opportunity to connect with and debrief with other IPC leads, so it was valued. But there was they shared and learnt how other IPC leads do their job. They heard that others have challenges similar to theirs, and that sort of provided that reassurance as well. And there was reassurance that they were on the right track. And of course, that can impact it can help build your confidence and your self-efficacy in the role. They shared new ideas, resources, links, and evidence, which is exactly what we want. And they also gave examples of taking what was learnt from a community of practice back to their workplace. And I've just got a quote there, great opportunity for IPC leads to share and learn from other experiences and be updated with current advice. So that was a Victorian pilot, and that was over a year ago now, year and a half ago, actually. So building on that, as I said, we thought, okay, we'll go national. We thought we would do a bit more co-design just with nationally rather than just the sort of Victorian taking what we learned from Victoria, but also building on that and just checking how we could make it enhance participation, I guess, make it more appealing to IPC leads, how we can maximise participation. We also wanted to know some of the practical side of things as well, how best to run it, how often, what topics to cover, those sorts of things. So back in October and November, we held online workshops. We had 5, and we ended up with 31 participants from around Australia. And then we also met with IPC lead managers and execs from 3 aged care providers just to check in with them as well. We summarised the findings from the workshops and those interviews and shared them with participants, and I'll present those findings in a minute. And the findings are now being used to inform the communities of practice, which we're in the process of finalising. So there were kind of 7 key areas that came up, or points that came up from the co-design workshops. Participants responded positively to the idea of a community of practice, seeing it as a valuable way to connect, share practical solutions and reduce the sense of working in isolation, which also came through in our Victorian pilot. So it's a national issue. And also many felt it would help strengthen their IPC knowledge, their confidence in the IPC lead role, and help with making a more consistent practice across the sector. Participants also emphasised that sessions should be interactive and practical, solution-focused and tailored to real challenges of aged care, which, that was music to my ears. That's what we want. We don't really want that didactic kind of webinar sessions, but we do want, really solution focused and, problem solving together. Share it, for example, sharing case examples, tools, resources, and outbreak experiences. These were viewed as particularly helpful. So hearing what others are doing and, reducing that duplication that happens across health and aged care sectors all the time. Across all workshops, the biggest concern was a lack of dedicated time for IPC lead responsibilities. This came through in the Victorian pilot. I don't think it's not new to us, and it's not new to doing research in aged care as well. It is something that with the staff shortages and the high workloads, it does make IPC responsibilities often takes a back seat, which is unfortunate. So there's competing priorities, staffing pressures, and difficulty getting off the floor can limit participation in learning activities, including attending a community of practice. So we've got to, work hard to make these communities of practice, seem really worthwhile and of benefit. Participants also highlighted the need for safe and confidential discussions, especially when sharing sensitive issues, but everyone felt that was something they can do. They do it all the time. It's part of being a healthcare professional. Ensuring representation from diverse services was also mentioned, so including regional, remote, standalone facilities and facilities that are culture-based. So that was viewed as important, which was nice to hear. So that's part of the research team's role, is really to make sure we are reaching out to include diverse participation. Attendance and engagement will also depend on organisational support. So it's absolutely essential that they have high-level management support, as well as from their peers, because often they'll be, covering them on the floor so they can attend the communities of practice. So it's needing support from everyone really within the facilities. Adequate staffing and clear recognition of IPC responsibilities also came through here. Many agreed that a letter or a flyer addressed to Resi Care executives or managements would aid in outlining the benefits of IPC support and assist in facilitating participation efforts. So we'll be doing that as well. The benefits that were discussed or expected from a community of practice: building confidence, especially for newer IPC leads, providing that practical guidance that is often missing from traditional training, encouraging consistent practice across the sector that came through, and shared problem solving. So things like supporting preparedness for outbreaks and emerging issues was also a benefit that came out. Most participants preferred short, structured online sessions supported by agendas organised in advance. So that will be our job, to make sure that people know about the sessions well in advance, and we were running them at the same time every month to help with that. The agenda side of it and the structured side of it. So I think we agree, and the literature also tells us that, it's okay to have a bit of structure, to have some structure. It's good. It's good for the planning, and so you're coming to the group to discuss, but also making sure that there is time and opportunities for a bit of unstructured or not as formal discussion, so that if people do have issues that they really want to raise, that they have that opportunity. So that's really important as well. There wasn't really any consensus on length, frequency, or topics. There are a range of responses, so we are leaning a little bit more towards what we did for the Victorian pilot, because we felt like it worked. And then with the topics, we met with the three IPC lead sort of managers to get a bit of a gauge on what they felt was important as well. So lots of topics came up, and we couldn't really hone it in on one or two until we had further discussions. So we ended up deciding to focus on antimicrobial stewardship. So that's what one of the areas that the community of practice might focus on, and the other area is transmissible infections beyond COVID-19. So the idea is that a community of practice will focus on one of these topics over the 12 months. We are currently recruiting IPC leads to join our communities of practice, and we've got enough people at the moment for 3. Very keen to have more IPC leads join. So please contact me or click on that link that'll take you to like a brief online survey where you can register your interest, and then I'll get in touch with you. And they are running for 1 hour once a month using Teams. Also contact me if you have any questions. But yeah, so we've got one group on AMS, one group on transmissible infections. This is so far, and as we recruit more, we'll set up more groups. And the other thing that came out of the co-design workshops, which I forgot to mention, was that in WA, it can be tricky to attend some of the sessions that are set up. Well, it's because of the time difference really that makes it tricky. So we are having a WA-based community of practice because of the time difference, and the focus will be on AMS. Again, if we get more numbers, we can set up a WA-based transmissible infections group as well. So yeah, please contact me. Please send the link out to others. The other thing to mention though is that there are research activities involved. That's how we evaluate whether it's making a difference. And there are some research activities like very short surveys at the end of each session, for example, just to make sure we're on track. So there will be before and after measures that IPC leads will be asked to do. So it's hopefully not too onerous survey at the start and the end. So it's a 15-20 minute online survey where we want to know about your confidence and satisfaction in the role, but also how long you've been in the role and how long you've been in aged care, just to get an idea of and a bit about your resi care facility that you work at, to make sure we are reaching diverse group of participants. We'll also be doing audits of practice among a random sample of facilities, which you'll hear more about if you sign up for the communities of practice. That's again, we're hoping that's not going to be onerous at all. And that's largely the research team doing that. And then after the 12 months of the communities of practice, we're hoping to get a little bit more feedback from participants. So we'll be doing interviews. That's volunteer. You volunteer for that, really to get a bit more detail about the IPC leads' experiences. And the other thing we're collecting are the costs to run the communities of practice. So this is important for future funding, but also just a lot of this information is lacking from the literature. We don't know a lot about this, so always good to add to the knowledge. I'd also like to, I mentioned the funding body, and I'd also like to acknowledge the Immerse 2 research team and expert advisory group. We're very fortunate to have lots of IPC expertise, researchers, clinicians, and consumers with lived experience. So we've got 6 people with lived experience. So they're current carers of people living in residential care or former carers. They've been they add to that diversity and bring that perspective along to the project. And very happy to take any questions. Although I'll hand over to you, Noleen.
Thanks,
Thank you.
Jo. Can I ask you to stop sharing your slides? And Gabby, could you please put your video screen back on? And mine's not coming back on for some reason. Use camera. Okay. So we've got time for questions, which is good. Kaz, will you lead those questions from the Q&A, please?
Yes.
Yes, of course. Okay.
Oh, which Kaz?
2 Kazes.
No, Kaz.
No.
Lead. Sorry.
Kaz Chen.
That's all right.
Sorry, Kaz Tursky.
No worries. So I think the first couple of questions is for Gabby, actually. So first of all, did your scoping review identify any implications for future research or practice?
Yes, they did. So from a practice and research perspective, these findings indicate that introducing digital systems without addressing integration, access for off-site prescribers, and multidisciplinary collaboration is unlikely to prove antimicrobial medication management. And for future research, it should prioritise the development and evaluation of digital AMS interventions that are purpose designed for the context of residential aged care homes, with consideration for the implementation process and the system interoperability, how they speak to each other, and make sure that there's shared access to clinical information, and that there's end user engagement from the start.
Okay, fantastic. And just another quick question: were any of those studies in Australia? And what did they find?
Yes, there was one study from Australia. It was an online survey for residential aged care facilities in South Australia. There was 54 residential aged care facilities. And what they found was that 74% of facilities use electronic clinical documentation systems, but 22% have hybrid electronic and paper systems. And that 81% used electronic medication management systems, but there was some, electronic and paper systems still used. And that study was the one that found that there was limited access for external providers, so GPs, and those not based at the residential aged care facility, that they did not have access or view-only access to the clinical records. So there was only one study in South Australia.
Thank you.
Jo's
Yeah.
turn.
Okay. I'm happy to hand over to you, Noleen, now that you've got your camera working
Yeah.
again.
Thanks, Kaz. Jo, this is from Lisa Hort. Do participants get CPD points for their participation, please?
We're looking into that. We've heard mixed things. So where someone said that a community practice doesn't qualify as CPD points, but yeah, that's something that we need to investigate further. So we are hoping, yes, because that will definitely help, I think.
Great. And again, this is directed to you, well, everyone really, but it's about COPs. It's always wonderful to have a podiatrist involved in this topic, as is often considered only nurses can do this function. I would be interested to know the thoughts of the group about how we can expand the concept of a COP into community aged care services. So I'm interpreting that meaning a community age, a COP that is multidisciplinary, more than just nurses. What do you think about that, Jo?
Yeah, absolutely. It's a little bit beyond the scope of the of our current research project, but we are looking at other, I guess, funding opportunities because if there's a need, it's certainly it's not that difficult to set up and I guess get started. You just need the enthusiasm, I think, of people and for them to have the time really to do it, to attend, and to participate actively. So the other group that we've had a lot of interest from are IPC lead managers. So these are they might be in a quality role, or they're not really on the floor nurses, but they're overseeing multiple IPC leads from across a provider or a group. So that's another group who we've had a lot of interest from, and we're looking at ways to support them in their role. So yeah, or I think community practice they can work for anyone. You just need that passion, that drive, that and that, I guess, that dedication or ability to come off the floor and participate. Yeah.
Yeah, great. So I'm going to give you a rest for a moment, Jo. I'm going to come back, Jay and Lisa, to your questions. I'm going to come back to you, Gabby, and ask, from the studies that you reviewed, what is the biggest barrier preventing staff from using digital tools? And what's the best enabler? So biggest barrier and best enabler, possibly what you've learned from the studies that you include in your scoping review.
Great question. From the studies, the biggest barrier, I think, was how these tools fit into the everyday routine of the people working. So even when the technology existed, tools were often described as, time-consuming or duplicative or not integrated in existing systems, which just makes it difficult to use, and it doesn't help support. So it's not the access to tools, it's how they actually integrate that ultimately results in uptake. And I think that'll be on the other side of that, is an enabler, is just that the digital tools support or make things more efficient, or they flow better and they can be seamlessly integrated so they can be used. And that's probably like the other side of the barrier, which is it's not working in their everyday routine. It does, and it supports and it helps make things easier process and helps the just helps the routines flow easier.
Sure. Thanks, Gabby. Back to you, Jo. Jay asks, how are you finding IPC lead roles establishment and protected time in public residential aged care services? Since different to the not-for-profits and privates, of course, they have an IPC team in their co-located attached hospitals.
I can only really speak to ones that were involved in Victorian pilot. And yeah, so we had a regional representative and one from affiliated with the Metro Hospital. I can't really say there was a huge difference. As part of Immerse 1, I should say, we looked at we wanted to know, did they have position descriptions, and that was mixed, that was varied. The larger providers, there were a couple of large providers where they did have written position descriptions, and I should say this is a few years ago as well, so it might have changed. Even on the government website, it has evolved over time. So and there was that evaluation of IPC leads that's been done. So things are changing and evolving over time. But is there a difference? I can't. Well, no. The thing is that they do have that connection to the hospitals. So, and really, I can only speak to what happened during COVID. Is they did have that that ability to call on the public hospital IPC experts who are often like in the regional areas. It's some of the wards. Sometimes they're wards that are mixed that have resi care component and acute care component. So yeah, there is a lot of difference in that respect. And if they're on site, so we had one hospital where the facility was on the same grounds as the hospital, so they, the IPC nurse consultant can just walk across, literally, and runs, sessions, for example, training sessions or PPE use sessions, or help with setting up. So things, yeah. So it's about, the access is definitely, access to expertise is there, but we still had IPC leads from resi care facilities in public sector hospitals interested in coming to the community of practice. If that's what that was getting at. Yeah, sorry, I did answer that in a very roundabout way.
Yeah.
But yeah.
Jo, will pharmacists be involved in helping to facilitate the AMS COPs?
We've contacted some pharmacists to help recruit IPC leads. Again, the focus is very much on the IPC lead roles who are on the floor. So nurses on the floor, resi care facilities. Hard to say at this stage. So because it is, the idea of a community practice is that the members, the people who participate, they decide what they want to talk about, what they want to, how they're going to achieve things, what goals they'd like to work on. So it might involve on-site pharmacists. I mean, but again, not all facilities have on-site pharmacists, so we have to make sure we're not excluding people because of that. Yeah.
Great, thanks. Coming back to you, Gabby. So as you were talking, I was thinking, how will the human-centered design approach you outline actually change the way these digital interventions are developed compared to what's been done before? It's very broad, but yeah.
Okay. Yeah, good question again. So I guess from the literature, many interventions are designed and implemented at scale at residential aged care homes without being tailored, as I've said. So the staff might not actually use them consistently or only partially, or feel like obliged or burdened by them, which can lead to low uptake. I think the key difference is that the human-centered design approach aims to understand these challenges up front, to see how they can actually fit into the day-to-day to make them more practical. But also there's limited research, so that's why we need boots on the ground per se, to get a better understanding of the context and see how we can.
Great. Kaz, did you want to unmute and ask a question?
Yes, a great session, thank you. And Gabby, it's great to see where this is heading. This is a question for both actually. So if we are really, with NCAS, we very much think about a learning health systems approach, and the first cab off the rank there is to understand whether we have the data that we need to drive clinical practice. We've obviously got some signals with ACNAPs, but I was wanting to know whether any of the themes came through around challenge with access to the data, and this would obviously be relevant for infection prevention as well, of course. Is there challenges with actually having the right data to help them in their improvement activities? Because we often find that you can have sort of working groups and scoping, communities of practice, but if you don't have the right data to understand where to go and how to prioritise and how to, even get your activities funded, it becomes very challenging. So, Jo, I was wondering whether that came out in any of your sessions.
It didn't specifically about the data, but when we advertised and how we're promoting the community of practice is we have mentioned learning about surveillance and how to audit and because I think you're right, the data collection is without it you don't know how you're doing. You've got to measure to improve. So we imagine, and I think we'll strongly encourage the communities of practice to think about how they can improve their measurement to know that they are making a difference. Yeah, because it's all very well for researchers to come in and do it, before and after. But yeah, if we want to make this sustainable, and we want them to also show their worth. That's the other thing that measurement can do. You can say, look, we've made this change, before and after, for example. Then, yeah, so I think that is something that IPC leads could potentially build their capacity or skill set to do. Yeah. Yeah.
Right.
I guess Noleen can probably answer this question, but over the last 10 years now, I think we've done a lot of real-time education for aged care facilities across the country, specifically talking about how to collect the data, what to do with it. Yeah.
Absolutely. It's fair to say if you're new to it, it helps to learn about the principles of collecting data and interpreting the data, because it's not quite as easy as you might think initially. It's important to do it properly, so for lots of reasons. So I'll just plug there that the aged care NAPS commences June the 1st and goes through to mid-December. So you may well already be thinking about it. If you're new to it, contact our support email, and we'll be able to talk you through how to do surveillance around antimicrobial stewardship.
Yeah. Oh, can I just also mention, the community of practice will
yes.
we'll also point people in the direction of existing resources. Like, we don't want people to be reinventing the wheel. They don't have that time. So yeah, if there are programs in place, that's the other thing that we hope to achieve. Yeah.
Yeah, good to hear. I just want to come back to the Q&A and note from the anonymous attendee. So in community, there is not a requirement for IPC per se, but it would be great, as you say, to have a COP that is supporting community-based services where it is not required, but is best practice model. Agree. And as you suggested, it'd be great to have a broader group, the nurses, quality persons, outbreak management lead, etc. Agree. And snuck into our chat line, we have a question from Court for you, Jo. The monthly meetings, there will be an agenda, or is it simply a drop-in session, and who initially will be facilitating them, please?
Yeah, so if we'll probably be using something similar to the Victorian pilot, where the first session or two, a member of the research team facilitates it, just until people get to know each other, and then if we we'll be asking the group for people to nominate as a facilitator or two. It's always good to have a couple as backup. So yeah, we're hoping that someone within the group will then step up as facilitator, and they'll be supported by the research team. So, for example, with the Victorian pilot, we met with one of the members of our research team, met with the facilitators beforehand. We set up a run sheet template that they could use if they wanted. It's really has prompts on it. And at the end of one community of practice session, you're just talking about, okay, what are we going to do at the next one and planning for that. So there might be agenda is really for meetings, but there might be, talking points or areas that they want to work on. But as I said, we don't want it to be too structured. Structure's good because the other thing we did for the Victorian pilot that I forgot to mention is we did bring experts in if that's what the group requested, like they wanted to talk about antimicrobial stewardship. So we brought Noleen in, but it was very much a Q&A, very practical problem solving session. So not that sort of webinar type session. So it's not really drop-in. We do want it to be interactive. We want a bit of commitment, because just coming to one or two, then we can't really say that that's what impacted the change. We do want that we'd like regular participation if possible.
Yeah, thanks, Jo. Kaz, you've still got your hand up from previous or?
No, new hand. I'm particularly interested, we've been in this space for a little while, and one of the challenges that we've found is the intersection between primary care and aged care homes, given it's the primary care GPs or others that are doing the prescribing. So have you had the opportunity to engage primary care in these community practice? It may not be the purpose, of course, Jo, but I was just wondering if there's any opportunity here for the primary care providers to be aware of the activities.
Yeah, we haven't I guess explicitly, no. They're quite a hard route to engage, to be honest. For any research in aged care, again, they're super busy. But one of our sessions in the Victorian pilot, it was about okay, because they do the prescribing, right, of antimicrobial. So how can as an IPC lead, how can I influence that? And Noleen spoke about this, but it's not about how you can change what the GP does, it's about what you can change yourself. And so, for example, doing the workup and doing the, all your clinical assessments to show this person with a UTI does not need an antibiotic. So, and doing that work with the family to convince them. And it's so it's really about building that confidence, the skill set, and thinking about and one of the care homes talked about being able to going back to their workplace, having a huddle with the nurses and talking about this very issue. So, but yeah, engaging directly with GPs, we haven't for this particular project, but it is something that is something that we need to continue to try and do. Yeah, happy to take any advice from people in the audience, but also we do have connections with our local primary health network. So yeah, I could potentially reach out to them as well. But yeah, it is a bit of a tricky.
It's extremely challenging. No one's going to deny that. And I think for most of us who've been in this stewardship space for a long time, I feel like they're missing out as well in some ways. And so, yeah, the drivers, it's trying to work out the drivers for engagement. I think that's the main thing. And I mean, the reason that hospital stewardship has raced ahead was because it was mandated and monitored every 2 years with the accreditation framework. It was mandatory. It's a mandatory criteria. So it's had to fund programs and had to step things up and had to meet But I will say that we think things have matured quite a lot in aged care, particularly with regards to the aged care naps, actually. And we're very excited about, I'm stealing your thunder here, Noleen, but we are really starting to modify and change the aged care nap so that we'll also be moving towards appropriateness assessments, which I think is a hugely exciting opportunity to drive that data for action.
Yeah, I agree, Kaz. I think that's ahead. We need, aside from looking at the quantity, we'll be looking at the quality of prescribing. I've got half a minute to thank you for attending, and thank you to our presenters, Gabby and Jo, both excellent presentations. I'll remind you that those presentations have been recorded and will be available on the NCAS website afterwards. Jo and Gabby both gave you contact details. I'm sure there's some interested persons online that will want to know more. So don't hesitate to contact them too. Next month's session will be on Wednesday, the 17th of June, on the theme of environmental AMR and AMS. So in closing, thank you, Gabby. Thank you, Jo. I learnt a lot. Always really appreciate your presentations. Thanks, everyone.
Thanks.
Have a
Thank
good
you.
day.
See you all.
Thank you for having me. Thank you.
Thanks. Bye.
Bye.